I invite the speakers for the panel discussion. Ryan, Marcella, Dr. Markel, please. Dr. Abushawa. Okay, we open the podium for questions.
I have some questions to just like stimulate discussions here. I thank you again for representing so well our program today. I think we really shine by what you've shown everybody who's here. So I was wondering if we can start with like Ryan and Marcella together. I think that one of the things we've done well and your presentations have shown is how like focusing on what the barriers are to break them versus focusing on more what's the candidacy, just saying not a candidate and moving on. I think that both your presentations have really shown sort of the philosophy we've adopted. And what are your thoughts on like that changing approach and how we're sort of performing as a transplant center with regards to giving access, right? Like looking at what the barriers are and how we can break them versus just assessing the candidacy and moving on.
You know, I think it really started when you came on board with the change in like the shift of, instead of finding a perfect kidney for a particular patient, what we really do now is look for a kidney to match that patient. So it doesn't really matter if it's a perfect kidney or not so perfect kidney, because a lot of our patients are not so perfect either. So we try to, be a matchmaker for them. So with that, the wait time here in New York is really long. It's like really 5 to 8 years. And so if you really were to wait for something, for a perfect kidney, you may not see that kidney before you end up doing not so well on dialysis. So, we've taken the approach that for every kidney that comes to us, we really try to look hard for a patient that would work on. That approach, we really have to look at our patients. And so we stratify them to see if they can tolerate like certain things like delayed graft function and stuff like that. But it really gives all our patients more access to all types of kidneys, not just the ones that are perfect.
Well, my part in this whole thing is the insurance part. And one of the things Tracy talked about is having home care, particularly for elderly patients. And sometimes that is the issue because contrary to all the wonderful things you see on television about these Medicare plans, they'll give them money to fly to Mexico and give them, lobster dinners and whatever else it is. It doesn't work that way. In order to access all of those benefits, a patient has to have a Medicare HMO or Medicare along with Medicaid. And that sometimes is the issue because Medicare doesn't pay for home health care. The only way Medicare pays for home, you have to be bed bound, and the only other place you'll be going is into hospice or to the hospital to die. Medicare doesn't pay for that. Medicare will get, people with Medicaid tend to get all of the home health care they want because Medicaid will give it to them. Another thing is, and with patients with private insurance, like the man we were talking about, sometimes some of the issue is medication coverage because every plan doesn't cover medicines. Okay, our plan, the Empire Plan, CVS, Caremark, we have good medication coverage. It'll cover all of the, if you are on transplant and you needed to spend $100,000 a year on medicine, which could happen, they'll cover $100,000 a year. Our co-pays are fairly low and you can utilize co-pay cards and of these types of programs to get lower co-pays. People with Medicare HMOs aren't so lucky. It's people that worked all their lives, have paid into the system, and then they retire, and all of a sudden it's bam, they have less benefits. Like for instance, 1199 patients. 1199 people have some of the best insurance in the city. They have zero co-pays for everything is a zero co-pay. But when they retire, they start having to pay co-pays. They may have 10% anti-rejection medications if you have Medicare or Medicaid HMO paid like Medicare Part B. So Medicare Part B pays at 20%. So if this patient only has Medicare, they only have United Healthcare, Medicare HMO, and they don't have Medicaid or something else, then they could be paying $50, $60, $100, $150 for one medication, and they can get steeper. My thing has been finding creative ways to get medication for patients. And like what Ms. Allard said about undocumented patients, one of the issues when I came, we wouldn't transplant undocumented patients because a lot of times once they were getting insurance through the dialysis units. The dialysis units were helping them with their paperwork and these types of things. But when they left dialysis, they didn't have that help. They couldn't recertify, they lost their coverage. And when somebody that's a resident or a citizen loses their coverage, I can go to a drug company and say, listen, you know, Marcella lost her insurance and she needs a program. I can go to that company, I can send in paperwork in, and 9 times out of 10, 9.5 times out of 10, they will approve that person's medicine and send it to them free of charge for a year. And if next year they need help, then I can renew it. But people that are undocumented, the only problem is if they lose their insurance, to get free medicine from a company, you have to be either a citizen or a legal resident. And that was the scary part. But now that we've been dealing with NOPI and we know that people are not going to lose their insurance, then it's not an issue. So that was definitely a barrier that's now gone. And, you know, it's hard work for all of us, and you have to be creative and you have to work hard, and you got to listen to patients complain, and patients want you to do miracles that sometimes you can't do. But, you know, all in all, you know, we do our best to make sure people can be transplanted. Yeah. Well, we didn't have to do that.
Okay, I'm Elsie Sherry. I'm one of the social workers. I have a question for Marcella. I am Haitian. In this community, there's a lot of undocumented Haitians, and a lot of them are very sick. And they're afraid to seek services because of their status. How can we bring some of these people in to ensure them that, okay, yes, you don't have, you're not documented, but we still could help you. What can we do to bring these people in to let them know that there is help here, that we could service them if needed?
Well, our outreach coordinators have been really great with that because they brought people in that are undocumented. They referred them to NOPI. And I remember one lady in particular, she's Haitian, and she came in and she kept saying, and we kept telling her, go to NOPI. She kept saying, no, they asked too many questions. I'm going to get deported. And we're like, they're not a part of ICE. They're not trying to set you up to deport you. They're trying to help you get insurance so you can be transplanted. So sometimes you have to reinforce that. I give them examples of other patients. I think since we started this, we've transplanted maybe 3 undocumented patients, 2 or 3. And so, and I told her, that's not what we're here for. We're here to help you, not hurt you. And I think after that, talking, she finally did go and get some help. So it's just reassuring them and letting them know that we're not setting them up to be deported. And because I think with immigrants, that's the thing. They think that it's us against them, and that we're trying to get them out of the country because we don't want you here. Go back to where you come, because they hear that all the time. Go back to where you come from. We don't want you here. You're a burden on the society. But they work, they pay taxes. I mean, and a lot of jobs that immigrants do, most of us don't want to do. And so, you know, they're vital to the economy of the city, the state, the country. And we have to just let people know that we are here to help them, and we're going to do whatever we can to get them what they need to get transplanted.
As I said, Marcella knows all the answers.
Okay, also I have a question for Tracy. Tracy, that was an excellent presentation regarding, you mentioned home care services. Okay, a lot of insurance do not offer home care services. Especially if there's money involved, this patient has a lot of money, resources and all that. You know, sometimes can the family chip in, or since this patient has X amount of children, can we get those children together and speak to them, let them know that, okay, then your parents may not be able to afford a home care services. Can they pay it out of their own pocket? Can there be, you know, somehow the children help pay for, let's say if they need home care services, will the children be able to help?
Great question. Thank you, Elsie. So collaboration is the key, right? So when we do an evaluation, we are collaborating with not just the patient, but also the patient's family. And so when we do talk their supports, we educate them on the process. That's a key in terms of, really providing that understanding of what this journey is going to be. It's not going to be, well, they have the kidney, well, I can go to Trinidad for a year, as soon as they're finished. Support is very, very crucial. And if a family does not have the means to provide home care services, we try to, work with them to think about, ways and means of how they can do it. For example, perhaps they can alternate care, right? If somebody works in the evening, then somebody will cover the daytime. There are many ways that we go around that. So we want to make sure that they have this kidney for as long as they can, and to really minimize the stressors. And we know that that is a stressor. Thank you.
Hello, everyone. I have a suggestion. I would suggest to you, sorry, my name is Edwidge Menard, and I'm also from the New York City Commission on Human Rights. I suggest to you that you will have your Haitian staff workers or, health educators go to the Haitian radio programs, because the community really listens to them. There are a lot of programs, and you can present there. Also, you can go to the Haitian Assembly and Council people, Rita Joseph, Sufran, Farah Lewis, Rodney Bichot, and ask them to have town halls in Haitian Creole. And you will have staff members who speak the language, and also those experts who do not speak, but they can be translate for you. So you can bring that information to the community, because, as you all know, immigrants, they are very guarded. But if you bring it to them in their community, in their language, then they'll be able to absorb, the information. Thank you.
Thank you.
Hello, everyone. I'm just asking a question about the prerequisitions for patient being transplanted. Like, how far in advance are they screened and informed of what to expect when they're getting a transplant or after they've gotten their transplant?
Ms. Egner, the question is before transplant or post-transplant?
Before the actual transplant.
Right.
So we like to see patients earlier the better, even when they're not on dialysis. There's a lot of testing that needs to be done, and the sooner the better, because then they can start to accumulate time. When we say the 5 to 8 year wait time, that starts when they start dialysis, or if they're listed preemptively when they're listed. So, the sooner the better. When their GFR is 20 and below, then they start to be eligible for kidney match runs. But typically when the patients start to see their nephrologist, when their kidneys are starting to fail, that's the best time to send to us so that we can start the work.
To add a little to the question, what he's saying is, if say you're diagnosed with a kidney disease, and your GFR, that's the way to measure the function of the kidney, falls below 20, GFR of less than 20, then you're eligible to get in line to be eligible for a kidney transplant. But you may take 5 years to get to dialysis, but you've collected 5 years worth of time, so that tomorrow when you're ready, because if you waste these 5 years and did not get yourself evaluated, the moment you get on dialysis, you have a form filled called 2728. That becomes your first day of waiting time. So these 5 years which you were eligible for is not there anymore, it's gone. So the key is early referral, follow through appointments, get on the list. If you're eligible with a GFR which meets the criteria, you start collecting time, which is the key to getting transplanted early.
But also, in regards to your questions, they get massive education the day they cross our door. And that's a regulation to get on the list. But we educate them about the risks and benefits of transplant the first day we meet them. That's like Susan and Maxine and Ryan's job to do thorough education. They also sit with a surgeon who tells them all the surgical risk and what to expect. And once they get on the list, they've already been educated about all that. And then every year that they wait for a kidney, we reinforce that education so that they're prepared. Do they always remember? Not always. Do they always understand what we said? Not always, as Dr. Markel has been able to say, but they're educated about what to expect and what the risks are from the day they cross our door.
Thank you.
1 second, Maxine, please.
I just want,
Maxine, 1 second. Serious. Yes,
Yes.
multiple lists.
Question for the people online.
Yeah, we're keeping track.
Sorry,
They won't hear.
yeah.
Yeah. And that is, so the question is, can patients be listed in multiple sites? And the answer is, I'm just repeating for the people online because they can't hear you. And the answer to that is yes. And it's a valid question because it used to be that there was a law in New York State where you couldn't get dual listed. But there is, since the KAS, that 2014 change in the kidney allocation, it actually wanted to stop disparities from state to state into listing criteria such as this. And so since 2014, patients are allowed to multi-list, or there's still centers. Is a center allowed to say, if you get listed somewhere else, I will not list you? Yes. But do you have to inform a patient that they can be multi-listed? So that's also one of the regulations. So the center can decide that they're not going to list patients who are listed in many places. Our center, our approach is we want everybody. We're Brooklyn, love is the way. And so come with us, we can be polyamorous. We have no problem with that.
There are more than 11 regions based on various zip codes. You can be listed in multiple regions. And in a region, you can be listed in more than one hospital. So if you're listed in Westchester Medical Center and in Downstate, if a kidney is coming from DC, you'll be higher because Brooklyn is closer to DC. If a kidney is coming from Syracuse, you'll be higher in Westchester, it'll be lower in the DC. So it depends on where the location is. You can be listed in multiple places. Yes.
Other patients that are able to donate, so there's a shorter way
It depends on the location. For example, New York City has 9 transplant centers. Each of them on average do about 100 to 200 kidney transplants. So of course, the list is going to be much larger. The competition is much tighter. But if you look at a place, if you go to New Mexico, there's 1 transplant center. I'm sure there are enough accidents, enough donors. So the list is going to be, it's demand to supply.
But that new allocation that kicked in 2021 is trying to break that barrier. The regional disparity, the difference between Connecticut and New York is going away with that new allocation system. The last disparity that remains really in terms of where you are listed is the center's attitude towards organ acceptance and recipients acceptance. And so there are New Yorkers who get listed in Florida, because the transplant wait time historically have been lesser there. But those these geographic differences are going away. But what remains is the center's behavior as the last sort of disparity. But that is good. That's sort of our identity, right? Here, so patients going forward are going to be able to look for a candidate like me, which is the best center. Yeah.
Maxine?
Good morning, everyone. My name is Maxine. I'm one of the kidney transplant coordinator here. This question is for Dr. Markel. Could you expand? I know Dr. Suresh mentioned about the EGFR, but to dispel the myth about if your GFR was less than 20, you wouldn't get a kidney. And we had a lot of disparities with that in the past, where Blacks were less likely to get on the list because their eGFR would have been higher than a white. So that has changed recently. And you could go far back into Dr. Markel, you could explain about the new rule.
Sure. Yeah, I think that's a really important point, that for those who aren't aware, there was a factor that was that changed the estimate. GFR is your filtration rate. That's basically your kidney function, but it's not actually measured. It's calculated based on something called creatinine. And there was a belief that for some reason that African Americans had a different level of creatinine for a given GFR. So there was up until a year or so ago, a different GFR was assigned if you identified as African American. And what happened is you had a higher GFR for any given creatinine, which meant that you could not get listed until your creatinine was at a higher level. So it kept people from getting listed at the same rate, at the same creatinine, if you were African American. That's been removed now. And there's actually now, we're being asked to look back and see if people were kept off of the list for a period of time when that factor was in play, and they're getting their time back. So this is something, this was a disparity that was noted. As I didn't have time to go into it. If you saw several of our slides, being identified as African American was one of the risks for less transplant rate. And, you know, it's obviously a multifactorial issue, but that GFR issue was part of it. And so, you know, that's a really important point, Maxine, and that's been removed from the calculation now. So everyone is calculated at the same way, given the same creatinine. And I think that's going to help a lot for our patient population.
Thank you.
Hi, my name is Julie. I wanted to say, I have a comment and then I have a question. And my comment is, if we're really talking about transplants for all, you guys are really walking the walk and talking the talk. And it's incredible. It's incredible to see. So I want to reflect that back on the team, because I know how hard you're working and you really don't turn anybody away, which is incredible. So I wanted to say that first and foremost.
Thank you.
Number one. Okay. And I really mean that from the bottom of my heart. Number two, so I worked in dialysis for many years, and there were so many myths that were being told to the patients on dialysis about transplantation. And it was like, and I would talk to my patients, and first and foremost, I was amazed that they weren't on the list before they came onto dialysis, because their kidneys had been failing for a very long time, and we knew it, right? So they came in with a fistula, but yet they hadn't been put on the transplant list, even though they were eligible. So, and when they would say to me, oh, well, you know, I'm not going to get a transplant. I don't want to take those medications. I'm going to end up getting cancer. Like it was crazy, I guess. So my question is, how do you work within the community? You know, not only like different ethnicities, different races, to dispel myths there, but also how do you work with the nephrologists, some of the nephrologists that are really kind of, these are the, I guess, the myths that they're, I don't think they believe it, but I don't know why they're telling the patient. So like, how do you combat that? I guess is my question. Sorry.
Okay, I'll speak to the nephrologist. I mean, first of all, you know, that the laws have changed so that now dialysis units are being, you know, they are incentivized to refer patients for transplant. So I think probably education is improving, because they do want their patients to come for pre-transplant evaluation now. So that was one of the reasons that the laws did change, you know, for both home hemodialysis as well as transplant. But I think you bring up a point that I tried to address in some of the last slides in my talk, which is, I think, you know, we have to work with community workers. We have to, you know, we have to go, we are having this conference in part that we're hoping that, you know, there's a lot of people out in the metaverse who are actually on. We have a very large number of people who are on Zoom listening to this talk. And we're hoping to educate nephrologists who may or may not come to transplant conferences. Usually, we're also educating the primary care providers. Many of them see patients quite late into chronic kidney disease, and they can refer also for transplant. So I agree with you that we need to improve our education, not only of the patients, but of the providers themselves. And that's one of the things we're trying to do today.
Thank you.
We have one more question from the group here. What is our approach to patient access and high BMI? I think Dr. Roshan should be able to answer this question very well. She really opened the gates for our, we are doing it here because of Dr. Roshan. How are we dealing with patients with high BMI? Oh, me, you answer, okay. So, before Dr. Roshan came here, we had a cutoff with the BMI, that is BMI's body mass index on who we were transplanting for. Now, we don't have a cutoff. We go by patient to patient and look at the patient as a whole picture, comorbidities and etc. And we're transplanting pretty much, our average BMI is 35. We have gone up to 42, 44. So I don't think that is clearly being a high BMI is detrimental to your health, but that's not a contraindication for getting a transplant. We surely advise people to lose weight, get on a healthier lifestyle. We have a dietitian who's supporting that. We promoted bariatric surgery too to help some of the patients, but it is not a contraindication for transplant. Yes, Ms. Agnew.
That are being discarded.
Need more patients.
Sorry. What are the plans to utilize the amount of kidneys that are being discarded going forward?
Okay, I'll take the question. So it's a two-sided coin. One, I think there needs to be better evaluation on the donor side where how we are evaluating retrieval of these organs. Somebody is very sick and the kidney is not good, probably getting them into the pool is not a good thing. Second thing, as we are doing here, you have to find a patient for the kidney. And as a surgeons too, if you talk, all that we did not do much DCD donors. DCD means donation after cardiac death. And Dr. Abhishek was talking about warm ischemia time, cold ischemia time. And DBD means donation after brain death. Patient's heart is still beating. Surgeon like myself or Dr. Roshan go in, open the patient, cannulate the organ and put it on ice or a pump and bring it to you. So the kidney was getting oxygen and glucose till the very last minute. DCD is when we let the patient expire because they have very poor prognosis. Once they expire, you quickly cannulate them. So the time they take to expire, but the longer it takes, sometimes can affect the organ if the patient is already sick. But it has to go in a bigger picture, right? I would say a 21-year-old DCD organ would be much better than a 55-year-old DCD with diabetes and hypertension. This person has lived for 55 years with diabetes and hypertension with the normal creatinine, but this is a 21-year-old person who has just died from a road traffic accident. So that myth has to go away. So we have to find a kidney for the patient. You have to look at the patient and the donor and the organ as a whole. That would make better utilization of organs.
We also need to find more patients. There are a couple of instances where there are a lot of kidneys that came through us and we just didn't have the patient for that kidney. We really believe that there's a match to every kidney. We just don't have that patient yet.
And we may need more information like so sometimes we feel like we don't have a match, and a tendency we've had is when we have these kidneys that have been overlooked by everybody, we'll offer it to the 70 or the 67 and up patients on our list that we think really need to get off dialysis because they're not gonna do well. But it may be that we're wrong. Like more and more we're seeing these patients, these kidneys that have been overlooked actually are working great. And then it makes you think maybe the 50-year-old could have had that kidney and benefited for a lot of years. So I think that as we transplant these kidneys that nobody was transplanting for many years, we'll get better data. We may realize that they have great long-term survival, these kidneys in the end, and be able to offer it to more patients, be less selective in who we put it in. That's one. And that comes to a lot of tools in transplant that are coming up is, for example, using AI as an assist tool to better match a potential donor kidney with a potential recipient, helping the surgeon and the coordinators in the middle of the night assess those risks and benefit and allocate the organ. So that's one. So AI is coming to kidney allocation. education. It's going to take a long time, but that's going to help us. And then like on top of the currently we have a lot of cold perfusion machine in New York becoming normothermic, which is like, you know, blood the temperature level of a perfusion machine to an organ, then helps you assess. You can assess if the kidney starts working on the machine, and then you know, oh, this kidney is working, right? So I can transplant it. And you can also, so these are all technologies that are coming to help us better assess which kidney is going to work and therefore transplant them more. So technology is going to help us, but also centers' attitude and referrals is also going to help us. Yeah.
Good morning. I'd like to inquire to the team up there what the feeling is about psychiatric patients and transplant. I currently work in psychiatric OMH facilities, and I do have patients that could be considered from transplant, but I really don't know what your conceptual thought is about that.
Tracy? Perfect.
I'm sorry. So that's a very good question. Again, we do not discriminate towards any patient that comes through our door. Whether you have a mental history, your age, your nationality, we do not discriminate. So a patient who has grounds for that we believe is unstable is not a candidate at the present moment. But if we believe that somebody is stable, but we want psych to really evaluate that patient to make that, help us make that determination, we will refer that patient to psych to, you know, get something in writing that this person is a good candidate. Because the ultimate goal is for us to have great kidney transplant outcomes. And we don't want psych to mental illness to be a major factor after the patient is transplanted.
I just want to say a couple of things too, that, you know, essentially we've been meeting monthly now with the psychiatry team to discuss patients where there's any question at all, to try to see if there's a way to remove any barriers to transplanting some of our patients with a psychiatric history who may or may not be unstable at the time. The issue being that some of the medications we use immediately post-transplant, including high-dose steroid, can worsen certain psychiatric illnesses. And then patients also have to understand that a kidney might not work right away, as Dr. Abishwar said, and it may be stressful to them and cause anxiety the first couple of weeks as they wait for the kidney to work. So there are certain aspects to transplant that could worsen psychiatric illness that's unstable, but we definitely want to, as you know, break any barriers we possibly can. So we've been working very closely with our psychiatrists to try to do that. Thank you so much for your question.
I think that concludes our morning session.